this is a pregnant patient. You can see the baby's brain here. And you can see the placenta is super abnormal. It's a very low-lying placenta. It's covering the os here. So the cervix is actually completely expanded. And so we have a placenta previa that's extending into the cervix, which is already kind of open. And this is the vagina here. And then this is the bladder. This patient had had 7 prior pregnancies, 5 of which were with C-section.
Wow.
So these are the highest risk patients for developing previa as well as percreta, accreta, etc. And so in this case, this was her C-section scar area. So this is like some of the leftover myometrium. And it just kind of disappeared here. And this is where the C-section scar was. So we were concerned also that there could be, and actually here, for example, we were concerned that there was basically some spectrum of a placental invasion into the very thin myometrium here. I find it's like really, really hard to tell. Like, is it accreta, increta? The most obvious is percreta, and it's going all the way through and invading another organ. We were looking carefully at the bladder here. So basically what they did for this patient, and another sign of any of those things is heterogeneity of the placenta, and then T2 hypointense bands. Let me pull up this Radiopedia example. Oops. So this is an example that was on Radiopedia. Wait, why can't I? Oh, yeah. Okay. And this is an example of those T2 hypointense bands. So they are basically bands of fibrosis. These placentas often have really abnormal vascularity within them and get areas of ischemia and fibrosis, and that's what causes these bands. So these bands are not flovoids, although these placentas can also have a lot of abnormal vessels. But for MRI, we don't give contrast in pregnancy, so we didn't see that the abnormal vascularity that much. Anyway, so what they did for this patient is they did a C-section. They actually had IR place balloons in the internal iliac arteries to decrease the blood supply. Like, they put up the balloon right in the operating room while they were doing the procedure to decrease the bleeding from like the placenta and everything. They removed the baby, and then they left the uterus and the placenta intact. And they gave the patient 6 weeks of methotrexate to shrink the placenta and the uterus. And then they did a hysterectomy. And when they did the hysterectomy, the final path was placenta increta, not accreta. Accreta is just when it's adhered to the myometrium. It was invading into the complete myometrium, but not beyond it. So everything we suspected about bladder or other things wasn't actually invading through. So they were able to just remove the whole uterus and placenta and didn't have to resect any other organs. They also did a cystoscope at the time of the procedure just to make sure that nothing was coming through to the bladder, and that was completely normal.
Are you sure that there might not have been accreta going on when you saw it? Because they treated with methotrexate and maybe the pathology regressed.
Yeah, actually, that's a good point. They did have like some adhesions to the abdominal wall and to the bladder dome. And so they did raise that possibility even in their operative report, saying like maybe this was treated percreta, like those adhesions. Yeah. But they were, that's why they wanted to give the 6 weeks of methotrexate, because if it was invading these things, I mean, resecting part of the bladder is much more extensive surgery. So they wanted to shrink it as much as possible and then be as prepared as possible.
So there's concern for right in the background.
I've had cases of, I think it was cervical cancer that I was fairly certain was locally invasive, and then they did neoadjuvant therapy, and the final path did not show those findings that I expected I was seeing on imaging. So I would imagine that this could be something similar.
Yeah, yeah. And actually we have, maybe next time I'll show you guys some cases. They do like tandem and ovoids, like they basically do intracavitary radiation for cervical cancer now. And so they'll put it and we'll get MRIs of it. And so you'll see like a rod going into the cervical cancer. And after like one round of radiation, it's completely melted away. Like the tumor is like disappeared. But they're inpatient when they do that. So they leave the rod in and they basically give 24 hours of radiation. And then when they get their post-op scan, sometimes the patients even deliver their tumor. Like it just like sloughs off, and I'd rather deliver it than have it.
I also find these accreta procreta cases quite challenging. We get about, I would say, on average, about one a month, maybe two a month, and it's never any fun interpreting them. And I kind of put them in three boxes. No, I really don't see much. It's pretty close to normal. Then a middle box where I think that there's abnormal placentation, but I don't see anything that I would probably want to call procreta that bad. And then those third cases where you start seeing changes that are convincing for procreta, like involvement of a bladder wall or clear invasion into fat or something like that.
Mm-hmm. Yeah, we like basically everybody in the room gets, gives their opinion. We all kind of come to some consensus. I guess it's better to bring up the possibility if you and then I use that kind of the history as like a huge marker, like especially when they have previa and then multiple prior C-sections is like, then the red flags start ringing. But they even have like a placenta clinic at UCSF. I met the people who like Lena Poder, and I went to one of her presentations and they said they even get it wrong about 50% of the time.
Wow.
So I told her next time I was going to FaceTime her, just so my 25% can go to 50%.